female patient with huge goiter posted for thyroidectomy. 32-year-old female patient. She was admitted 2 days back in our hospital and with a complaint of swelling in the anterior aspect of the neck for the last 7 years, which is gradually increasing, more so in the last 1 year. She had no difficulty in eating or swallowing, but she had difficulty in breathing when lying down, especially in supine position, but no breathing difficulty when sitting or standing. She complained of occasional waking from sleep at night. She doesn't complain of any hoarseness of voice, but she complains of frequent palpitation and also anxiety for last 8 to 9 months. Excessive sweating and heat intolerance for almost the same duration. She did not complain of any dizziness, syncope or chest pain, or there is no history of easy fatigability or lethargy. Bowel and bladder habits are normal. No significant weight loss or gain in recent past. She is unmarried and her menstrual history is normal. No addiction history and no similar complaint in the family. No other significant past medical or surgical history. About the drug history, she is now taking carbimazole 5 mg twice daily and propranolol 20 mg once daily for last 1.5 months. On examination, she is conscious, alert and cooperative. Thin build, weight about 48 kg, height about 160 cm. Pallor, cyanosis, jaundice, edema or lymphadenopathy were not present. No tremor was noted. She was afebrile. Her radial pulse was 68 per minute, regular, normal volume, no radioradial or radiofemoral delay, with no special character. Blood pressure was 126 by 78 mm of mercury in supine position, equal in both arms. Heart sound, first and second heart sound were audible and there was no added sound. Respiratory rate was 15 per minute, regular, abdominal thoracic. The trachea was not palpable. The chest, bilateral vesicular breath sound was heard. No stridor, wheeze or palpitation was heard. Abdomen was soft. No organomegaly was noted. Peristaltic sound were audible. There was cranial nerve examination revealed no abnormality. The peripheral reflexes were normal and the gait was normal. Coming to the airway examination, there was no visible deformity in the face. Neck movement was adequate. Interincisor gap was 3.5 cm. Tongue was normal in size. Malopatic rating was 2. Dentition was normal. Thyromental distance about 9 cm and sternomental distance was about 14 cm. Jaw movement was normal. Trachea was not palpable. Coming to the examination of the swelling. The swelling is in the anterior aspect of neck, size about 8 by 9 cm, and it is extending from upper border of thyroid cartilage to between the two sternocleidomastoid muscles, and the lower border was not clearly visible. The surface was smooth. It is moving with deglutition and protrusion of tongue. The overlying skin was normal, visible, and distended veins were visible, but no visible pulsation. Temperature was not raised, and all borders were palpable except the lower border. No bruise over the swelling. Coming to the investigation, the hemoglobin was 11.4 gram per dl. Total count of 5,600 per ml. Platelet count was 3,20,000. Fasting sugar was 84 mg per dl and postprandial was 116 mg per dl. Urea 16 mg per dl. Creatinine 0.8 mg per dl. INR was 1.1. TSH was 0.1 milli-IU per liter. Total T4 was 30 microgram per dl. Total T3 was 200 nanogram per dl. And I only could get the free T4 level. that was 2.5 nanogram per dl. The sodium was 138 millimole per liter, potassium was 3.9 millimole per liter, and chloride is 106 millimole per liter. She had an ECG done 2 months back. Her recent ECG was not done, and in that the rate was 90 per minute. Sinus rhythm, the axis was normal. Chest X-ray, the lung pits are clear, no cardiomegaly, trachea elevated to the right side, and a huge thyroid shadow visible in the neck extending to the superior mediastinum. And X-ray of neck lateral view was showing evidence of compression of trachea. USG neck revealed a large thyroid with thyroid mass with the left lobe greater in size than the right lobe, and clearly defined capsule with no infiltration of large vessels. CT scan showed multinodular goiter with retrosternal extension causing mass effect on the trachea and brachiocephalic veins and branches of arch of aorta, and no infiltration into the surrounding tissues. So my provisional diagnosis is a 32-year-old female with multinodular goiter with retrosternal extension having features of hyperthyroidism, at present controlled with medication, posted for total or subtotal thyroidectomy.
Do you think this patient is fit for surgery? To be taken up for surgery? Or you want to do anything else?
So the patient may further benefit from optimization of her thyroid function status because her TSH was 0.1, which is subnormal, and her FT4 was elevated. So I'd like an endocrinologist to look into her medication and possibly increase the dose of carbimazole or provide alternate therapy, sir.
How much time is good for a patient to be treated with antithyroid?
It's about 4 to 6 weeks.
4 to 6 weeks. Right? So how long this patient has received the drugs?
For 6 weeks.
6 weeks. So maybe we have to prolong it a little more till the patient's TSH levels start coming up. They're quite below normal. What happens to T3, T4 in the brain? Which one is the active form? And
T3 is inactive. It is T4 is converted into T3.
what is it called? In the brain. DiO2. Right? It is in the brain. If you look at the conversion, is the active form is supposed to be the
FT3, sir.
free T3-4s, right? So it is called that deoxytriiodine, which is there in the brain, which the level should also be looked into. Right? At times you should be measuring them. Now, if you have this patient, we would definitely like to put her on antithyroids. Is she on a beta blocker?
Yes, sir. Ketorolac.
What is her heart rate?
68.
68. That is a sleeping heart rate or a resting heart rate or
Resting heart rate.
resting heart rate. So anyway, the heart rate is quite satisfactory. So that is what we will need to do. Now the other problem is patient has a retrosternal extension. So what's the difference in thyroidectomy for retrosternal extension versus the patient who doesn't have a retrosternal extension?
We may have to do thoracotomy to.
Yes, so they may have to split up the sternum and then take out rest of the thyroid. But you have to do a CT scan properly in this patient. Without a CT scan, it doesn't make any sense. Because we need to know how much of the thyroid tissue is beneath the sternum, whether the surgeons can still extract it or they need to go for a sternal incision. Most of them would be able to retrieve it off, but at times they may have to split open to get the complete thyroidectomy done. Okay, especially if it's producing a pus. Go to your CT finding. I think what you have told me is absolutely incomplete. What I would be interested in the CT finding is any information you want apart from a mass effect on trachea. So that's the most important investigation. Yes, you need to know what is the narrowest, which is the narrowest part, at what length from the glottis it is, right? And what is the extent of narrowing. So if you don't have that information, you will not be able to decide what sort of tube you should put and how will you manage this case. Is it clear? So you need to have all the transverse sections, see 1 millimeter slices, and then calculate what is the extent of narrowing, right? Vertical extent of narrowing. How severe is the constriction? What is the minimal diameter which you have available? Because that should correspond to your endotracheal tube. Now one thing always remember, which all of us miss, and we have a very big misconception, is that when the trachea is displaced, even in CT it tells you that the trachea is displaced laterally. Correct? Anytime when you have a thyroid swelling, until unless it is the isthmus which is swelled out, any of the lobes, if they swell, the trachea would be pushed laterally. So you have to look whether you are able to expand this trachea or not. Whether this compression which is occurring at the trachea can be relieved by any mechanical maneuvers. The books describe that you lift up the thyroid. How a lateral structure would be relieved by lifting up the thyroid? Trachea is never displaced posteriorly. It may be lateral, it may be displaced posterolaterally, but it will never come posterior to the thyroid gland until unless only the isthmus is enlarging, and that's very rare. So what you have been described by lifting up the thyroid actually is a wrong phenomenon. What should be doing is you slide the thyroid laterally. So push the thyroid to the opposite side, that may relieve the constriction, especially if it is in the cervical trachea itself. But if it has gone retrosternally, you have no control over it. And that's why CT scan is a big help to tell us how far it is going. Because you will not be able to manipulate that constriction. And your external diameter of the tube would be calculated, your length of the tube would be calculated by that, which has to bypass that constriction. Now if the constriction is narrow enough, like it is 4 millimeters or 4.5 millimeters, then your size of the tube left is very minimal. You hardly have anything. So when you are not able to negotiate the constriction and you have all the possibility of losing the airway, what is your rescue plan? What will be your rescue plan?
Rigid bronchoscopy, but I'll keep the femoral artery and femoral vein access available. And it cannot be done as an emergency.
It cannot be done as a last resort.
It
has to be a planned resort. So if you tell me that you are going to keep CPB ready, it is not going to make any sense. So you have to have it ready and you have to go on it. And initially, the first thing which you do is not to put the tube but to put the rigid bronchoscope. We make a mistake of trying to intubate, it is not going to help. The tube will not be able to negotiate that. Correct? So if you put the rigid bronchoscope, you still have a chance that posteriorly it is only membrane, anteriorly the cartilages are there which are not going to anyway give you any hope of expanding. Only posteriorly the trachea can be pushed a little bit more because you only have a membrane there. So you could push in a rigid bronchoscope, that can give you some dilatation initially. So after rigid bronchoscopy, then you try to intubate. And you should be ready to go on the pump. Femoral, everything should be cannulated. Because if this attempt fails, the patient goes on bypass. Your circuit would be there, everything would be there, and you have to take that chance to save a life. It's something very difficult you have presented. which you would not be managing on your own. You will require super consultants to come and help you. And it will be a team effort of cardiothoracic surgeons, your endocrinologist, the anesthetist, the surgeons there. So it's a very big team decision which you have to take, not at a PG level. I will give it as a question if you are doing DM. So here for you it is better to talk about multinodular thyroid, which is commonly kept in exam. And what I have just told you about your retrosternal extension, just remember these finer points. That bronchoscopy is not a rescue. It is the first choice in such patients when you have constriction is retrosternal and you have no access to it. And the constriction is too small to be negotiated. Okay? Secondly, cardiopulmonary bypass is not something which is done in emergency. It has to be electively planned and you should be prepared to immediately go on pump without wasting time. And the third is push the thyroid, if it is only cervical, push it laterally to the opposite side rather than pulling it up. At times pulling up helps because the trachea anyway gets displaced upwards. I mean, this thyroid gets displaced upwards, so some opening is there. But if you push it laterally, you will have maximum opening of the trachea. I will show you one slide. Once this discussion is over, in 2 minutes, I will show you a CT picture and I will also show you the ultrasound, how it works. Okay? Okay, now we come to the management of thyroid. Now let us consider this, that the tracheal narrowing is occurring in the cervical area, in the cervical trachea, and it is not going into the retrosternal extension. So how would you manage this case? The hyperthyroidism has been managed by adequate drug control. Now how would you go about and anesthetize this case? And what are your prime considerations during surgery and anesthesia?
Right? This is an X-ray neck which was taken. Now look at the CT. You look at the CT, you see the trachea there? Completely laterally. Have a pointer here? Pointer is there? This is the trachea. Okay? This is the trachea pushed completely laterally and it is about 5 millimeters. That is the diameter which we have. That means the external diameter of your tube should be 5 millimeters. Beyond that it may not accept. The only thing which can go through this is your rigid bronchoscope. It may dilate the trachea up further because it is only the soft tissue or the tracheal tissue, the thyroid tissue which is surrounding it, so it can be expanded laterally. Correct? So a rigid bronchoscope would help you to dilate, so that should be your first choice, not as a rescue measure. Now, look at this picture. This is again the X-ray chest. Look how much it is compressed here. This is how it is pushed. So every part of the trachea is pushed laterally. Now I'm going to show you a video. So this is very misleading, right? That you have a misleading kind of a thing that the trachea is very narrow. These are all static pictures. Even if you take a VRT, which Dr. Aruna was talking about, that the volume of the trachea can be measured and it can tell you a three-dimensional thing. But now when I do an ultrasound, right? Look what is happening. I'm pushing the trachea to the side. I'm pushing the thyroid to the side. And look at this trachea. It is expanding. Yes, it is opening up. So what have I done? So my MRI pictures become inferior to my ultrasound. My ultrasound has showed me that even if it is 6 millimeters, but if I just retract the thyroid laterally, my trachea is normal. And this patient was having difficulty in breathing. The moment I retracted the thyroid laterally, she was able to breathe better. And she said, I want to keep my hand there, I'm fine. That's why we could do this ultrasound, we could repeat this procedure again and again. See, that's the trachea. Now I'm pushing it. See how it expands. So what I mean to say is that it is not the right idea to lift up the thyroid. Okay? So if you look at it, look at the CT scan carefully, look at the orientation of the trachea to the thyroid gland. certain mechanical measures can make your life extremely easy. Okay, and it's a non-invasive one. The patient will tell you how she feels. So all which is given in books sometimes needs to be challenged. Here if I lift up the thyroid, it is not going to help me. Right? Only the lateral displacement of the thyroid has what has helped me. Because even in the CT scan, if you look at this picture, if you look at this picture in CT scan, the trachea is extremely lateral. It is not behind the thyroid. If it was behind the thyroid, then maybe lifting up the thyroid would help. So how you are going to open up the airway, this CT scan pictures will tell you. But you should have that mind to know what you are looking at. So it is not only the diameter of the trachea, I want to know the extent of narrowing which is, but I want to see how I can open the airway up. So for that I need something. I can ask the patient to hold it and take repeat CTs also. That's not a problem. But her hand will come, but she'll be exposed to another radiation and all. So just an ultrasound, keeping it there, seeing whether the tracheal shadow, and believe me, this tracheal opening is above the narrowing. It's just above the narrowing. It's not really reaching till the narrowing it is. So the narrowing would have opened up considerably. If the upper portion, which is just beginning to narrow, has opened up, I expect the one which has narrowed down would have opened up completely. To a great extent. Even 2 millimeters would have made a difference. We measured the diameters. If you want to see the static measurements which we have done, I can show you how much it was in each of the planes. So when we measured it here, it was about 9.2 millimeters. And when we displaced and took the picture, it went up to 12.5. So we have opened up by 3 millimeters. So getting a 3 millimeter, like 5 versus 7 size tube, it makes such a big difference to us. So just keep it in mind when you talk about preparation. It is all about preparation and planning, that what are you looking at, how are you going to prepare yourself, what you're going to do with the airway in thyroid or in any other case. Thank you.
So for the airway management of the surgery, head up position with extension at the neck, we can use a sandbag between the shoulder blades.
How much head up?
10 to 15 degrees head up.
How do you measure?
So we can measure it from the bed hinges. It's an approximation since we don't have angle measuring devices on our tables.
Can you tell us clinically how would you make out that this much amount of head up tilt is good enough?
Looking at the gym,
Looking at the neck veins. Need not be internal jugular, just the neck veins, whichever is visible. So you move up slowly till you find that the neck veins disappear or draining. Because if you do not give that draining position or venous drainage is not proper, there will be a lot of oozing from the side. Is that right? Yes. So remember that how you have to position. Then you will have to have an extension line which should come up to you so that you don't interfere for the thyroid. What is the blood supply for thyroid?
Inferior thyroid is a branch of the thyrocervical trunk, which is a branch of the first part of the septum.
What's the difference between hemithyroidectomy, subtotal thyroidectomy,
total thyroidectomy? What is the difference between these type of surgeries, and how does anesthesia get affected by this? What is hemithyroidectomy?
One lobe of hematoma.
What is subtotal?
8 grams of the 8 grams of, 4 grams on each side will be left to parathyroid gland.
Parathyroid. What is total thyroidectomy? Are they able to preserve generally?
It can be like taken out and implanted in muscle patient.
So, but generally everything is taken out. So what are the problems you will find post-operatively in such patients? Let's say total thyroidectomy. What problems can happen in such patients?
Hypocalcemia related problems.
When does it manifest? 4 to 40 years. What are the immediate complications of thyroidectomy?
Airway edema, airway obstruction because of hematoma.
So now the patient is just been extubated, shifted to the post-operative ward, and you find that the patient is having difficulty in breathing. The sister there or the nurse there has called you, and you go there and find out that the patient is having some stridor now, right? And we expect that some amount of bleeding is occurring, and that is why there is a compression. So how would you manage that patient? In a post-op recovery room, patient is after 15-20 minutes, you find the patient is having some stridor.
The removal of the suture lines or the staples is the ultimate treatment, ultimate correction of the etiology.
Isn't that correct? If you just remove the
And drain the blood, drain the collecting hematoma, sir.
how do you drain it? Would you intubate or just ask the surgeon to drain it?
Simultaneously, I will go ahead with the intubation,
So
sir.
you will have to intubate the patient.
Yes, sir.
Right. Where does the blood collect? Why does it cause obstruction? Under what layers the blood would start collecting and cause such an obstruction of the yeah? Yeah, below that, right? So there is no place for it to escape. So it keeps accumulating, and that is why the compression occurs. So unless you remove that layer, the patient is not going to benefit. So remember, these patients would require intubation, and then they have to go beneath the muscular planes to get the hematoma evacuated, find out a bleeder if there was any, and get hemostasis and then come back. Right? Now what happens if the patient with such a huge thyroid has a suspected tracheomalacia? How would you manage? And how would you know that the patient has tracheomalacia?
Qualitative sleep test after confirming the qualitative
History given by the patient will be suggested. So the patient will be having distress on supine position.
That may be because of the huge thyroid. How do you confirm that the patient has tracheomalacia?
Fiber optic bronchoscope before extubation.
You do that? That will splint the catheter. The small airway exchange catheter is going to splint the airway. How do you know the patient has tracheomalacia? How is it first diagnosed?
Patient presents with stridor after extubation.
This patient doesn't have, but would still have stridor because it is too narrow. It is done at the time of surgery. The surgeon will tell you that the trachea is deformed. They can palpate, visually see. So what factors will influence your extubation plan if tracheomalacia is confirmed during surgery? What factors will influence your extubation plan if the surgeon tells you yes, there is tracheomalacia?
The extent and the degree of tracheomalacia.
Yes, absolutely. You have to find out there whether it is one cartilage, two cartilages, three cartilages, how much it is collapsed inside, how is it holding back, is it deformed only on the side, is it deformed, the whole cartilage is deformed, or only a small portion of cartilage is involved. So when you visually inspect and palpate that area, then you will come to know what is the extent of tracheomalacia is there. So you can't use tracheomalacia very loosely. Sometimes it will not cause any problem. The tracheal stability is still there with the rest of the cartilage which is supporting it. Only a small portion is damaged. Or only one portion of one cartilage is damaged, rest of the rings are intact. So you will have to visually inspect and see. Then of course you can do the leak test. How do you do a leak test?
So the cup of the tube is the cup of the endotracheal tube is deflated, and there are several ways of doing it. So we can monitor the volumes that is going in and out of the lumen of the endotracheal tube. If there is a decrease in endotracheal, the tidal volume after deflation of the cup,
How much?
150 ml. I'm not sure about the balance.
Almost that much. About 10 to 15% or about 100 ml or more. Then we say yes, there is definitely a good leak around the lumen. Always remember that doing it initially with the amount of air required to give a sealing pressure, then again doing it again, it doesn't work out. So this is the simplest way of doing it. Seeing your expired tidal volume on a patient who is completely paralyzed, right? Completely paralyzed on volume controlled ventilation with the same tidal volume which you were ventilating earlier. So you just deflate the cuff and see whether the expired tidal volume has fallen by about 100 ml. Right? If it has fallen down and your leak test is positive, you don't have to bother about it. But again, this leak test should be performed again after the skin sutures are there. When the trachea is open, when the muscles are not covering it, it may give you false results. But once the muscles are sutured, skin is sutured, then it may not be positive. Right? So it is not that once you have done it and it is fine with you. And whenever you have an extent which is large and there is a suspicion of tracheal collapse, it is always good to make sure that you pass in a airway exchange catheter and then take out the tracheal tube. But again, in these patients, when you expect so much of tissue to come out, I would recommend that you always ventilate these patients post-op for some time. That gives you some time to decrease the airway edema if it has occurred along with your tracheal malacia. So give that time for that edema to resolve. So you can use steroid. You can even push in a small tube by the side of the endotracheal tube into the oropharynx, and through that you nebulize epinephrine. Right? So you just put another tube by the side into the oropharynx, and that will be a conduit to deliver the smoke, which is the nebulized epinephrine over the glottis area, and that will take care of this. Because with the tube, if you nebulize, it will all go beyond the constriction into the lungs where you don't need it. So you can use certain ways of reducing the edema. Ventilate for about 6 hours or 8 hours or maybe 12 hours if you have the facility. And then if you have tracheomalacia, you should bring the patient back to the theatre. Preserve the ventilation. This is one area where you should remove the tube with the patient under deep inhalational anesthesia. Right? The patient should be very quietly breathing. The more labored the breathing is, the more strain he makes on respiration, the collapse will intensify. So a quiet, after you have educated the patient, told the patient, counseled the patient, everything, under deep spontaneous breathing, deep inhalational anesthesia, you remove the tube over a tube exchanger and let the patient quietly come down. So slowly the patient will come out of it, and then you will be able to make a judgment whether the patient is able to sustain the airway or not. If there is a tracheal collapse again and stridor is happening, re-intubate and immediately go for tracheostomy. That should be the plan for tracheomalacia. Is it clear? So So this is how you systematically manage these patients when you have a suspicion of such things.
Is it possible to re-intubate a patient who is having a tracheomalacia?
Yes, it will move up. When it is a mobile segment, so when the tube goes inside the lumen, it will be pushed up. When it's being pushed down, it will be pushed up. It's a variable orifice. So that is what will make it. Okay, any more questions you have, we can answer, otherwise we will just wind up.
Any questions, any queries? There are plenty to catch. You just can't keep on.
So some things which we have told you of our personal opinions and I have showed you certain pictures, you can use it for your future practice of anesthesia, but when you go into the exam, you still tell them that you will lift up the thyroid. Yes.
I have a question regarding the previous case, the cleft lip, cleft palate. So you have said that you will insert the rice tube and then give the paracetamol intro. Sir, is there chances of aspiration because you are giving
5 ml of paracetamol? 5 ml of paracetamol?
I'm just asking, I don't know.
No, there is nothing of that sort. It gets absorbed into the stomach itself. So what you do is you put in a rice tube once you have mask ventilated the patient. And invariably, in all kids 6 months old, you would have encephalated the stomach. So you'll have to decompress. So the best way to decompress is either you push in the suction catheter or you push in a small feeding tube. So having the feeding tube there, 5 ml of paracetamol, right, would not make much of a difference. And then you have the oral cavity there where so much of blood is going to be there, right? So all the surgery is going to last for another 1.5. Left flip, I anticipate about an hour, right? An hour or two, maybe. By the time, where will 5 ml go? Correct? So that the time lag is enough, and the volume is too small to justify any kind of an aspiration.
Sir, please share your experience regarding the fluid management in adult patients. Various versions we have read, but means how you manage the fluid during the intro in adult patients.
Okay, to make it simpler, let us talk fluid management in patients who have major surgeries, right? For normal surgeries, I mean, you give anything, nothing will happen. But where you really want fluid management, which would make a difference in outcome, major abdominal surgeries, for example. Thoracic surgery, where you have to limit your fluid to almost 25 ml per hour or 50 ml, not more than that, almost half the amount which you will normally give. So I would not give more than 1 liter to a patient whose one lung is removed. Other abdominal surgeries, when you have a patient who has to be managed for fluids, where major fluid shifts are involved, it is always better to go by dynamic parameters, like stroke volume variation, right? Like your, the other parameters which are there. Sometimes we take into account only the stroke volume. I would put an echo probe and look at the LVOT tract. Aortic diameter always remain constant, so I will just measure the VTI, that is the velocity time integral. And I will see whether my passive leg raising would increase the VTI. If it increases, I know the patient is fluid responsive. So fluid management for major abdominal surgeries where larger fluid shifts are required depends whether your patient is fluid responsive or not. If the patient is fluid responsive, which you can easily do by doing a passive leg raising test, where you are mobilizing about 300 ml of patient's own blood volume, and if there is an increase in stroke volume, what I need to measure is the stroke volume. So stroke volume is well measured by your Vigilio monitors which you have, which will tell you immediately, or blood pressure too, but blood pressure is not doesn't have a good sensitivity, though it has a very high specificity. Right? So you can use these measures to see whether your patient is fluid responsive or not. If the patient is fluid responsive, then it is easy to give fluids, replace that fluid. And once you are given that fluid, then it is alright. But if you have to give a bolus of fluid, I will use 3 ml per kg body weight. That will be my bolus. Specifically patients who are critically balanced. Initially I may give 10 ml per kg body weight to make sure my cardiac output increases to the maximum, and then when it is plateauing, I'll stop giving fluid. Correct? And afterwards, you measure your urine output. What is the output coming out? Replace that by an input, so that the balance is always maintained tight. So the idea of measuring urine output is not to see after 3 hours whether urine has come or not. So in the first hour, if my output has come out to about 75 ml, I am going to replace that by 75 ml. So what is coming out, you give that. And if there is a blood loss which is happening, right, then you do a passive flag raising test and see whether the patient is fluid responsive, whether you need to give certain boluses of fluid. So it is all these parameters which you will take into account to actually tell you how the goal-directed fluid therapy can work. So CBP doesn't help us now, it is a static one. You will have to use certain dynamic parameters like cardiac output or stroke volume measurements or stroke volume variation measurements, along with your PLR. PLR is the best one because you have not given anything, you have just utilized the patient's volume and seen whether there is an improvement. If there is an improvement, give that 300 ml of colloid and the patient's blood volume will improve. So that is how we would do it in major surgery.
Sir, large thyroid mass patients suddenly presenting to ER where it is not planned. It is a severe respiratory distress. We had such patient a few days ago in our hospital. So where we cannot have the time to even assess the extent of the thyroid invading the airways or not. Patient just presented with severe respiratory distress. We found inspiratory stridor. So in that case, what should be the airway management? Because we have to first manage the airway. Patient comes on without any report, without any prior checkups, suddenly lands up with a severe respiratory distress, finding inspiratory stridor. We will go for paralyzing and then try for intubation. We don't know about the airway. So what should be the plan? And tracheostomy, we also found difficult. The surgeons tried for a low tracheostomy. They could not find any recess. Mass was inside. They tried for a high tracheostomy. Meanwhile, we had difficulties to manage the airways. We could not do anything. So, what should be that approach in this case?
Call your consultant. You will not be able to manage it. Even I may require some help to tell me what it is. I generally have one of our very good ENT surgeons. He will come along and both of us will try to manage. So such patients, when they come to you, first step what you do is call for help. I'm not joking. Call for help right in the beginning. Second is let the patient be in a position where she or he is in the most comfortable one. They will most of the time they will be sitting up. Let them sit up. Don't try to force them to lie down. So once they are sitting up, at least get an IV line, put them on oxygen, see your humidified oxygen, see that the saturation is maintained. At least get an X-ray neck, because sitting position and neck X-ray can be done without having the patient to lie down. Just like a PF thorax picture, you will be able to get a picture in that sense. You may not be able to get CT. So higher imaging is not possible, but at least the basic X-ray neck will tell you how much is the constriction, what is happening. And always, just put an ultrasound probe onto the thyroid. Even in the sitting position, put an ultrasound probe onto the thyroid. It will at least tell you if there is a cystic swelling or a thyroid abscess which is compressing. If you find that, your problem is solved. Right? So rule out certain things which are immediately manageable there itself. Correct? And your ultrasound will also tell you the position where it's, maybe you can use such mechanical maneuvers to retract the thyroid laterally, see whether the patient is able to breathe well. And then in that position you try to intubate. But in narrowed trachea, please do not attempt fiber optic laryngoscope or bronchoscope. 6 millimeter diameter narrowing, and if I have to put a fiber optic scope 4.5 millimeters into the trachea just to see the narrowing, which my CT is anyway telling me, how will the patient breathe? There is no lumen for the patient to breathe. She will be suffocated to death. So don't try those maneuvers which would not help you in any way. If you are able to negotiate the constriction, right, with the tube, that is the best. But that fiber optic is not going to help you. How is fiber optic going to help you to negotiate the lumen? The only way it can be helped is by rigid bronchoscope. So what you should be doing at that time is call the ENT surgeon immediately. You take an X-ray neck and you tell him immediately, once we induce, put the rigid bronchoscope in. That will dilate the trachea. He can take out the rigid bronchoscope, then you try to push in your tube. So that should be what your plan of action should be, according to me. Do an X-ray test. Just confirm with an ultrasound to see if it is a cystic swelling or an abscess. If possible, drain that. If it is a large thyroid mass, try to see if you can somehow mechanically open up the trachea, like I showed you here. Right? If it's possible to do that, most of the time it is possible, remember. Because one lobe of thyroid is going to push it to the other side. But if it is bilateral lobe involvement, right, then you can still expect that the trachea would be pushed posterolaterally, not completely posteriorly. So at times you can try pulling, you can try retracting to the side. That will help you to actually see if you can open up the trachea. Get the ENT surgeon, get the rigid bronchoscopy straight away in, and then dilate the trachea, put the tube in, and then the things would be settled down.
What was the outcome of the patient? What happened?
Actually, we made the patient sit. She was having strike. She was.
Finally happened to the patient.
হ্যাঁ, বেঁচে ছিল। ওরা ট্রেকিওস্টমি করেছিল, হাই ট্রেকিওস্টমি করেছিল, লো অ্যাপ্রোচ করে পারিনি, করেছিল। And আমার
Rigid bronchoscopy, there will not be any tracheal disruption forcefully done. There is complete narrowing and aspirating.
You have to be careful, you have to select the size of the scope which you are going to use. We can't use an adult scope right in the beginning. We have pediatric scope which we will use to see the lumen and then decide what to do. When you discriminate in this Okay, thank you very much. It's time for us to leave.